assigned to talk on ECMO fundamentals. So vast topic because the titles given are indications, implementation, monitoring. ECMO itself is so many configurations. So I just want to briefly touch upon the ECMO circuit basics. ECMO is the odd man out. It is not in the cardiology community. It has been patronized mostly by the heart transplant surgeons and the intensive care unit people. So, but it has a lot of applications in interventional cardiology. We should be familiar with the device. Let me just touch upon the circuit basics, and then I can try to focus on VA ECMO, that adult cardiac ECMO, 5 cardinal presentations. ECMO is a modified form of cardiopulmonary bypass. Basically, it is a temporary mechanical circulatory support with an extracorporeal gas exchange. There is an organization called ELSO, which was founded in 1989, which keeps the registry of the real-world patients. You can see the first successful ECMO patient. There were a lot of gadgets around. There is no space to move around, which has transformed into miniaturized portable device, nothing but a cardio health, which is being used nowadays even in the area of arrest, even outside hospitals. Some people, you might have seen the familiar picture of people did a resuscitation in the France railway station. That was a very popular image. And having said that, despite this device was not patronized by the industry, you will be surprised to see there is a rapid growth of ECMO. Almost in 2017, more than 350 centers of more than 9,000 cases done by ECMO. So this therapy has a real value in our daily practice. Why should there be a rapid growth? Because it is an easy to insert device. There is no need for any imaging guidance. And more than anything else, it is a one platform serves all. You can see the latest Lancet 2020, which suggests that ECMO can be used in all forms of ventricular dysfunction, whether it is isolated, biventricular, or a witness cardiac arrest, we can use this. So it's a very wonderful device. All cardiologists must be familiar with. And the components of ECMO is basically, you can easily understand this, basically to support heart in the form of a console, a drive unit, and a pump disposable, that is a centrifugal pump. And in the form of blender and oxygenator membrane lung, which is made of polymethylene pentane with hollow fibers through which the blood is being transfused so that the gas exchange occurs, and there are cannulas. And I can tell you one thing, in the past, most of the studies in ECMO were more of a registries, and in the past, the technique of cannulation is not like the contemporary large bore access devices, as we cardiologists have a lot of knowledge after this TAVR and structural programs. We can do this with the help of ultrasound guided large bore access, which can minimize this complication. The only downside of ECMO in the past was limb ischemia, which can be very well tackled with the contemporary large bore access devices, techniques. These are the two types. You know that VV ECMO for ARDS or a severe respiratory failure, whereas the VA ECMO for the adult cardiac ECMO. Having said that, this is the basic idea that there is a drainage cannula, which is usually from the femoral vein, and it goes to the pump and then to the oxygenator and getting oxygenated and returned back into the arterioles. This is the basic principle of ECMO. And having said that, you should know some mechanics of this ECMO. That is, when there is a centrifugal pump, obviously there is a negative pressure just before the pump. That is, from the vein to the pump, there is negative pressure. This pressure should be maintained somewhere around -40. If it is too negative, obviously there is no volume, there is no preload. Then between P1 and P2, that is between the pump and the oxygenator, this is the segment which says if the oxygenator is failing, obviously there is an increase in pressure in this area. And post oxygenator, that is after the oxygenator, that is the P3 segment. This is this area, there is a P3 segment. So this P1, P2 and P3 are the three important things one must be aware of that. And the delta P is the pressure gradient, that is P2 and P3. If there is an increase in delta P, then obviously the oxygenator is failing because of the clot or big air embolism, etc. Basically, this device is functioning on, it's a load dependent machine. It is functioning on the amount of preload as well as the afterload. And also it depends on the machine configuration, that is cannula size based on the Paisoli's law. If you know that the cannula diameter is big, obviously flow is big, there is no resistance. If the cannula length is obviously too much, then obviously resistance is more. So you need to design the cannula size and based on the patient's anatomy and the requirements of cardiac support. These are the 5 cardinal considerations, which is a nice article by Dr. Prashant Rao. The cardinal considerations are either an indication, the number one indication, that is which patient you need to select. Suppose if a patient is in hemometabolic shock, recurrent arrest, those are not the patients to put on ECMO. So you need to first define whether this patient has a recoverable or treatable. Need not recover. Treatable means we can bridge them to VAD or transplant. This is a basic point you have to understand. We have to understand before putting the patient on ECMO. The second one is cannulation strategy, then monitoring in the form of whether the patient develops LV distension or a distal limb ischemia. And finally, we need to find a way to exit, whether to bridge them with a VAD or a transplant. These are the major indications as far as cardiologists are concerned. The cardiogenic shock, both ischemic and non-ischemic, or mechanical complications in MI. Witnessed cardiac arrest or in-hospital arrest, if we do the proper ECMO-supported CPR, we can get almost 29% survival rate as per the literature, and also bridge to recovery and intervention. Mostly in the advanced heart failure transplant team, they are using this as a bridge device. And the last one, though not much robust data, there are some single-center registries which says that even in patients with high-risk PCI, like a lost remaining vessel with adverse hemodynamic features, you can use that. So basically it is a bridge. It is not the ultimate therapy. It is a bridge to another situation. This is the technique. You all know that, femoral to femoral. The only thing what I have to stress upon, there is another form which is called as subclavian to internal jugular vein, this one. This is theoretically better because the patient can ambulate. The patients who are waiting for a transplant can have this one, and also it reduces the differential hypoxemia theoretically. Let me take you through a high-risk PCA in which I have done a high-risk PCA with a ECMO implantation. Basically, this patient has a 62-year-old multimorbid patient, had an inferior wall MI 2020, primary PCA to RCA, had recurrent heart failure, and then this time he presented with NSTEMI, LVF stabilized in ICU with decongestive measures with some dobutamine. He had a NSVT, severe LV, moderate MR, elevated filling pressures. And angio showed that the RCA is CTO in the ISR and the LCX is almost near CTO. On the LAD, left main LAD, you can see diffuse calcified tight lesion. The MRI showed non-viable RCA that is infarcted territory. If you look at this patient, obviously one can say we can go for a PVAD, but the issue is twofold. One is clinical issue, clinical challenge, other one is economical challenge. The clinical challenge is obviously this patient has been having some hypoxemia, requiring some oxygen, and had a VT. I thought we need to have a full support when the patient crashes on the table, so that is the one. The second one is the ECMO in our center at least is 1/6 the price of PVAD in this country. So this is a surgical turn down. This patient was turned down by a surgeon. So we need to offer them some form of therapy. So I thought we can go ahead with the ultrasound guided access. Always we must hereafter, even for the regular coronary procedure, we must take ultrasound guidance because it will tell you about the diameter of the vessel morphology, calcium, so that we can avoid complications. Then we put arterial cannula, which is 15 French, though it can only flow up to 3 liters. It can tide over the crisis, and venous cannula of 21 French. The one thing we need to know that when you are connecting the cannula, there must be some air. So you must be very, very careful in relieving the air when you are connecting this cannula. Otherwise, the oxygenator will fail. And the gas flow should be in such a way that should be equal to the circuit blood flow, whatever you are going to give. So we have connected it. You can see that one Y connector, what we thought, let us try with a single axis like in, what do you call that, in Impella. But unfortunately, in our country, we don't have the adapter, so we cannot do that. We have gone with the other axis, just for an interest only, nothing else. The other side was okay. Then we went ahead with the Rotapro and then cutting balloon. You can see that cutting balloon has cut middle LAD and even the left main, but whereas in the osteoproximal LAD, there was a nodule. You can see from the IVUS, there was a nodule there. Then we went ahead again with IVL. As the panelist and the chairperson told very well that I could observe that whenever you are doing IVL in such patients of a prolonged ischemia, prolonged inflation, during rotablation, I didn't have any issues, but during the IVL, the patient went in for sudden, not a gradual hypotension, because the patient was already on 2.2 liters of ECMO flow. So he didn't develop any sudden arrest. He developed slow hypotension when we had to increase the flow a little bit at the expense of increasing the LV filling pressure. I could understand, but that one we have managed with the dobutamine and some diuretics. So you can see the post-IVL, there is a nice cracking of the calcium and the area is also more than 9. So then we have stented this, and then I just thought of going ahead with the LCX. I think I have done the L6, it seems, yeah. So LCX with a drug-coated balloon, we did a provisional approach here and with a good area of more than 10. So this is a pre and post echo. So though there is not much improvement in LVEF which can happen in a week's time, I could understand one thing, the LVOT VTA has much improved. You can see the LVOT VTA that shows there is some improvement in stroke volume. And the patient was managed in the ICU 2-3 days with some diuretics and dobutamine, little minimal support, and he became well. Now coming to the monitoring and management, this is very simple that whenever you are starting the ECMO, you have to give a full anticoagulation, almost the ACT should be more than 300. Our practice is the first day we usually monitor with the ACT, with the maintenance ACT of 180 to 220. These are all from ELSO guidelines. You all know that. And also you should watch for bleeding. You should check for the hematocrit as well as platelets. And if there is any hemolysis, as Dr. Sanjog nicely showed you, that if you suspect a hemolysis in the urine bag, you can do a LDH or a plasma-free hemoglobin. Again, the plasma-free hemoglobin availability and affordability is also. So we usually go by LDH and other measures and fibrinogen, FDP. The routine X-ray monitoring is essential to know the cannula positioning and to anticipate the white lung syndrome, that is LV distension and pulmonary recovery also. This thing you must focus upon. This is the one thing which is very essential whenever you are monitoring the ECMO, the P1, P2 and P3 segment. Then if there is an increased negative pressure in the P1 segment, that is before the pump, in the venous system, obviously there is a hypovolemia. So some blood loss is happening, or it may be due to the ventilator associated pneumothorax, or cannula may be malpositioned. So you must be aware of that. If there is oxygenator failure due to clot formation, obviously again the P1 will be reduced because the PT will go. That is, before the oxygenator, the pressure will build up, that will slow down the pump. So naturally the P1 will be going down. So these things, whenever you are managing ECMO, this chart is very essential to remember, and you can see this with the help of your intensivist. And this is a very busy slide just to show you about these are the various things you have to monitor, starting from the coagulation profile, circuit, hemodynamics, nursing care, etc. Complications are twofold. One is circuit related, as I told you, the oxygenator failure, clot, and the other one is patient related. I'm not going into the circuit related things. Pump failure, decannulation, spallation of the tube sometimes, So Bioline coated tubes are better in this situation because they are resistant to rupture. Air embolism, oxygenator, clot formation failure. Let me come to the patient-related things. Harlequin syndrome, this is the one you all know, that blue hat and upper body is deoxygenator and lower body. And the previous speakers have discussed well about this one, because when the heart is recovering faster and the lung is lagging behind, obviously you will get a good cardiac output. So naturally the deoxygenated blood will go into the upper body. Remember, whenever you have such problem, always start with the clinical examination. See the arterial pulse, if there is a pulsatility, and see the right arm oxygenation. These are the things will tell you whether and also X-ray, which will tell you whether the lung is improving. And there is a strategy called VAV ECMO, that is again taking the oxygenator blood and putting it into the venous circulation. That may help you in counteracting this one. This is obviously you all know that this is the condition where, because of the large cannula, and you have to daily look at the limbs in terms of temperature. NIRS is the one which we are not having. NIRS, that is also easy. The other thing, previously when we were discussing, I was about to ask you, when you are putting a large cannula retrograde and a distal perfusion cannula, we always have the habit of our practice of decannulating surgical means, because in between area there is a dead space. That space, once in our case, that space had a thrombus and the patient gone in for, after the heart recovery discharge, a week later he came with a limb ischemia. So in a patient with a prolonged, monitoring in ICU, we always, like in a shock patient, 2 weeks of, we always do a surgical decannulation, except in some patients like HRPCA, we can do it. This is one another point I want to stress upon. And this is the thing, you know, that this sheath should be braided sheath, it should be ultrasound guided, should be in the superficial femoral area. You have to go well above the bifurcation of the femoral artery to put it. It should be braided so that it should not be kinked. 8 French is enough for distal perfusion. And this is, you see the chattering because of the volume loss, because of there is some perforation somewhere in the vessel which has caused it. Cardiogenic shock, I just touch upon it. So having said much about ECMO, you see the mortality is dismal, very disappointing. Why it is so? Because this is not a cardiac support device, this is only a circulatory support device. And you can see the flows, when the flow goes from 1 to 4.75 liters, naturally the stroke volume decreases, the LVEDP and LV systolic and diastolic volume, everything goes up. So you need a kind of venting. And also, always you should never expect all the patients to recover or to go to the futility. That is what the current cardiology practice. We always work tandem with the heart transplant team. We should always try to encourage the patient the first week of ECMO itself to go for a crossover, either a VAT, Centrimac, etc., which is very well evident from the Siddharth experience. You can see the early crossover and the late crossover. There is a big survival advantage out of it. And this is a transplant center from our city, which they have done from 15 to 23, almost 35 patients bridged to LVAD and the transplant, which has got almost a survival of 64%, mortality is 46. This is from Chennai. And so we always should encourage our people to go for, from first week onwards, we should motivate them, counsel them. This is the ELSO registry. If you look at this, there is controversial discussion may arise. There are a lot of studies and the large and retrospective and meta-analysis showed IABP has no effect in venting, whereas this ELSO registry, which is the real world practice registry, it shows the venting has in-hospital as well as on-support survival advantage. And 90% of the venting was done only with IABP because it's a real world. So IABP with the 50 cc is still recommended strategy and depends on the amount of venting you want to do this. This is the 8 strategies in which I can say the surgical venting and Impella is the one which is really useful. I am overshooting, so I just finished upon this is the lava ECMO. This is the one thing for in terms of our country, it is the more useful one because this is twofold. It is advantageous because it is cost effective. Number 2, it avoids 2 arterial cannulation. So we can avoid the complications. This is a 5-year experience from Kentucky. So basically, when we do some treatment, the treatment should be also cost-benefit ratio apart from cost-effective. That is what I want to imply. And the key message from this talk may be the survival and MCS management in the Indian context is cost and resource intensive. But we hope that increasingly better outcomes should be obtained if we bridge to therapy, LVAD and the transplant, because so many state governments are sponsoring transplant therapy. At least in my state, the transplant is being sponsored by the government. With meticulous ICU care, one can achieve at least 60% in profound shock patients if we bridge them at the early stage. We need to have some India-specific guidelines also for the practice purpose. And key to success, I have taken from one of the speakers from Europe. This is the way to success. It's a teamwork. It's not a single man's strategy like a IVL or a ROTA. It's a teamwork. You need an intensivist, you need a heart transplant surgeon, and you need a perfusionist, almost very important to have a success. Thank you so much.